All right. Well, we got 1 minute after the hour, so let's go ahead and get things rolling. Welcome, everybody. Great to see you. Thank you so much for joining us. This is actually our 5th session of our primary care learning community. And today's topic is telehealth. We think it'll be pretty popular. There's a lot going on in the telehealth field thanks to COVID and especially around primary care practices. We've got a super panel lined up today to talk about it, but I encourage all of you to get engaged in the conversation. If not out loud in the chat. What did we say, Teresa? We want to have a party in the chat. So really bring your questions, your thoughts, observations, engage with each other through the chat. We'd like that to keep rolling. So we'll go ahead to the next slide. If you haven't done it already, as you join, please go ahead and put your, who you are and where you're at in the chat, and we can help us keep track of who all has been able to join us today. So we can go ahead to the next slide. Here's what we have planned today. First, myself and our center director, Dr. Arlene Bierman, will provide a few welcome remarks just to set the stage for the rest of the conversation. Then we'll have a panel discussion. You see, we'll have 4 panelists, and Teresa Walnes will help facilitate the discussion around the panel. And then we're gonna have a wide open Q&A. No small groups today. There's gonna be a big group, all in one place having a discussion. So it should be fun, lively, and hopefully very interesting. So we'll go ahead to the next slide then. And with that, Arlene, I'd like to hand it off to you to say a few words of welcome to all 75 people have joined today. So we got some good numbers out there.
Yeah, so welcome everybody, and thanks for joining us, and a special thanks to the panelists. And I think, with the COVID-19 pandemic, I think one of the most amazing things was how resourceful and resilient so many primary care practices were, especially in transitioning to telehealth. And we've learned a lot. We've also raised a lot of questions. So I'm really looking forward to the discussion and the presentations today to see what have we learned, what do we know, what are the implications for primary care moving forward, but also what can we do to make sure that telehealth remains a robust but effective and accessible and equitable part of our delivery system moving forward. So I'll turn it back over to Bob, and welcome everybody.
Great, thanks, Arlene. That's terrific. And I'm just going to say a few words of background just to remind folks, if you haven't been to one of these sessions before, this is really ARC's primary care learning community. This was part of our response to COVID when it became really obvious that not a lot of the federal COVID response was focused on primary care. And we were hearing the struggles and challenges that primary care was having as it struggled through the pandemic. And we know that there's many organizations like yours that work to support primary care practices and help them adapt to new methods of care delivery during COVID-19. So we brought together this group to talk about what some of those issues were, and really to work in partnership with you and regional and state and local organizations who work directly with primary care practices to try to address some of what those needs are. We really set out to do 3 things over the course of this. It's really a time-limited learning community. It's really going to run about 6 months or so. We wanted to have a series of webinars and small group discussions, and we've talked about whole person care. We've talked about how to build trust and vaccine confidence. We've talked about the role of practice facilitation during COVID, and really COVID outreach from primary care. And today we're going to talk about telehealth. We've also tried to get resources from you that you find helpful and put them out in a newsletter that we send out every month just to help share resources that are of value. And then lastly, we wanted to pull together a white paper to try to make sense of what we heard from you over the last 6 months. And we're well underway to put that paper together. And we're hoping maybe we'll even get it into a manuscript that we can submit to a journal just to get a sense so people get the primary care struggles during COVID on people's radar again with some of what we've heard from you. So with that, today is the next in that series, and we have put together a special panel today that'll be led by Teresa Walnes. We can go to the next slide, and this is who's going to be on the panel. I'm going to read you very quick bios. Their bios are quite long. Sorry, guys, I'm only going to read the first 2 sentences so we can get quickly into the discussion. So let me just give you a tee up of who these folks are. So Teresa Walnes is a medical informaticist who fuses bench-based biomedical knowledge with implementation science with the goal of implementing evidence-based strategies for precision health for people with chronic disease. She leads projects focused on developing tools to identify and characterize people with chronic disease using electronic health record data and adapting evidence-based practices for chronic disease management into effective clinical care. She'll be moderating our discussion today. And our four panelists, first, Dr. Nino Mahante is a pediatrician with over 13 years of experience in community health, hospital-based medicine, academic medicine, policy, clinical quality improvement, research, and international volunteerism. Dr. Mahante currently serves as the Chief Research Officer and Director of Evidence-Based Practice of Alliance Chicago, a national network of community-based primary care practices that spans 21 states and over 200 clinical delivery sites. Next up is Andrew Bienstock. Andrew is joined the Department of Family Medicine in Colorado in 2017 as part of the Practice Innovation Program, where he's the Clinical Health Information Technology Advisor. Get it? Clinical Health Information Technology Advisor, CHITA, my favorite acronym in healthcare, where he manages that program. Andrew has been working in quality improvement, information technology for practice transformation, primary care since 2006, supporting practices participating in meaningful use, the physician quality reporting system, and the quality payment program. Patty Rose is also joining us today. Patty serves as a senior quality advisor at the Purdue Healthcare Advisors and joined the PHA team in May 2014. In this role, she supports the Indiana clinicians in understanding and meeting the requirements of numerous national and state quality initiatives, including QPP, MIPS, and serves Indiana providers through the Indiana Medicaid Promoting Interoperability Program. And then last, but certainly not least, Chris Wethington is Director of Practice Support at North Carolina's AHEC program. He's responsible for a team of over 32 practice support coaches that assist independent primary care and specialty practices with quality improvement, health information technology optimization, practice management, and value-based care programs. Chris has over 25 years of healthcare administration experience in practice management, clinical network and business development at a large healthcare system and state rural health program development in North Carolina. Okay, my goal was to read your bios in less than 5 minutes. Hopefully we came pretty close. Sorry for not doing them justice, but at this point, Teresa, I'm going to turn it over to you to lead our fabulous panel, and thank you all for being here today.
So first off, thank you. I want to say really a big thanks to the ARC team, and particularly Bob and Arlene for giving us the time and space to talk about this. It's just amazing as I looked on the list of people here. I know so many of you, and I hope to know so many more of you, because this is such an incredible community that we work and live in. So thank you to those of you who have been able to join us this afternoon. And of course, I will thank my panelists too, but we'll thank them sort of after we do some introductions. I kind of want to just set the stage a little bit, so where some of this comes from, and sort of flash back to March of 2020. But even longer than that, my background here is that I was fortunate to help to set up a Health IT Regional Extension Center in 2020. And through that really developed a really serious commitment to helping folks in primary care use technology effectively. I mean, there's lots of things that primary care needs, but this was the one place that I felt like I could make a difference. And, so when March 2020 happened and suddenly we all stopped flying and started to deal with what was going on with the pandemic, the first thing that my team and I sat down with is like, wow, how do we help our community? How do we really help make sure that the primary care community that we work with, like that we're there for them? Because that's what we could do, right? We weren't going to be front and center patient care, but we thought maybe we can help the folks who are doing that work. And so of course, the first thing I did was say, well, who can I talk to? And I reached out to my friends, I think in our primary care community that does technical support, particularly Health IT Regional Extension Centers, Health Center Controlled Networks, our folks who are in the AHEC community. I mean, it's an incredible, beautiful community of people. So I hope what you'll see today is this great group of people at the panel is just a small sample of all the amazing community that's out there doing work. And my hope is that by sharing who they are, who they work with, and what they do, it'll start and be the catalyst for great conversation afterwards, because this isn't just about us. The hope here, I think, is that we learn from everyone, because that's really what this was for me and for my team, was the chance to learn and to share new ideas. So with no further ado, I'm gonna get the people talking who have who have the important points of view here. So first of all, and I do this a little bit round robin just because we've got a lot of folks here, but I wanted to sort of start off our conversation just by helping people see the perspectives that are represented here. So I'm going to start with you, Andrew, and I'll move through the rest of the group. But tell us a little bit about, anything else we need to know about you from your bio, but also tell us a little bit about your practice community that you work with and sort of the state of things, March 2020, and maybe a little bit about where those practices are now so we can understand just sort of where we started and where you're going.
Okay, great. I'd be happy to. Thanks, Teresa. So I work at the University of Colorado Department of Family Medicine, and we have a practice innovation program where we work with a lot of different grant-funded projects. So we'll be a grantee for ARCS on a healthy alcohol use project. We did Evidence Now in the past. We had a state innovation model grant that we worked on for a few years. And just to give you an idea of our model quickly, we work with many different organizations within the state. And those organizations like the Health Information Exchange, or in one case, an insurance company, other agencies, they work as practice transformation organizations on these grants, where they're providing practice facilitators to do coaching with we work with a lot of small practices, 1 doc practice, 2 doc practice. We work with FQHCs, we work with other system-based groups, but really a lot of small independent providers, which is great. So when we're working on these different grants, we're really working directly with these practice coaches to help support them, provide support to practices on these projects. So I just want to give you a little bit of background there. In terms of kind of what we saw initially with the pandemic, one of the things, my focus area too, is really on a lot of times clinical quality measures. How do we track the data? What are we asking from the practices on the grants? How do we collect it? How do we QA it, et cetera? So one of the nice things we were able to do early on, we made a decision to collect data on telehealth visits. We thought, okay, we're collecting baseline data. A lot of these projects we were on were starting right at the beginning of the pandemic. So we were asking for baseline data from, at that point, it was 2019. We were asking for projects to report, practices to report on 2019 data for whether it's on a healthy alcohol use or other measures we were collecting. So we asked, let's look at telehealth visits. So how many practices were reporting that they were doing telehealth? How many visits were they doing in 2019, et cetera? So we can kind of get a baseline. And then we kept tracking that over time. So every time we collect metrics moving forward for all of our projects, most of our projects, we're asking for telehealth visits. So one of the things we saw is, in 2019, as you might expect, not a huge uptake of telehealth. And then come Q1, Q2, 2020, you started seeing those numbers rise. And we've seen those numbers rise for Q2, Q3, Q4. Q1 2021 was the first drop that we saw, where saw a lot more in-practice visits and not as much use of telehealth. So which I thought was pretty interesting, which kind of mimics what's going on, but still interesting nonetheless. So that's just kind of a little quick snapshot of kind of where we started, where we are, some of the data we're collecting. Thanks.
Wow, that's really exciting. And so Patty, I'm going to sort of move on to you and share your perspective from Indiana.
Sure. Thanks, Teresa. And I know Bob gave kind of a high-level overview of what I do, but Purdue University, Purdue Healthcare Advisors, we're in Indiana, and we also serve small rural providers, much like Andrew, 1, 2 docs. We have some larger groups as well that we serve, primarily with MIPS and quality improvement, quality measures. And when I have a bit of a passion of social determinants of health too, and telehealth, even before, like Andrew said, before in 2019, I started to get really interested. I saw the value in this. I said, this is really huge. Why aren't we using this more? And then boom, the pandemic hit. And, a lot of people say the silver lining in all the pandemic was telehealth coming forefront, and folks, the providers, patients seeing the value in telehealth. A lot of our clients, and I'm sure everyone can agree, within 48 hours, they switched, boom, a world shut down and they switched to telehealth. A lot of them, big clinics, within a week, all their providers were providing services through telehealth to keep the revenue going and to serve the patients. Patients are our primary customers. And so they really struggled. A lot of them, some of them were savvy with the technology, others weren't. We stepped in here at Purdue and reached out to all of our clients, do you need help? What can we help you with? And so it was a real changing scenario, but it's a good thing. And back in March 2020, we were really busy. Most of our clients were using telehealth. It has slowly trickled down since then, but there's still, some of them are using it 2-3 days a week, and some of them didn't fit well in their practices. We do work not only primary care providers, but many specialists as well. So a little bit of both worlds, but yeah, there's no going back. Telehealth has improved, done so much for the healthcare world. We can't go back. So that's a little bit about where we are at here in Indiana.
Thank you, Patty. I mean, I think that's a really interesting point about the sort of a rise and fall just a little bit. In other words, as things change, we continue to see this sort of evolve. And we're still watching things equilibrate a little bit. So Chris, give us your sort of how you see things from North Carolina.
Well, my experiences are similar to Andrew and Patty. You mentioned earlier, we've got about 32 practice support coaches, and they do a lot of work with quality improvement and helping practices standardize workflows to help, maximize clinical outcomes. And now we're starting to look at things from a health equity standpoint as well. But we had a lot of experience in EHR optimization, getting data out of EHRs, helping practices figure out which EHRs make the most sense for their needs. And we are also training practices quite a bit on the health information exchange and how to use that tool and integrate it into their workflow. So when COVID happened, it was like overnight, the water burst out of the dam, and we had to figure out telehealth very quickly. So a lot of primary care practices, especially the independent ones, the FQACs, the rural health centers, the health departments, they were flooded with all these telehealth offerings. And the providers, especially the independent ones, if they did not adapt and adopt telehealth, they were going to go out of business quickly. And we literally have providers working out of their dining rooms, like I am right now, seeing patients using telehealth. And it sort of became the wild, wild west of like it did in the early days with EHR offerings. There's still a lot of them out there, but there's some good ones and there's some bad ones. And a lot of them are being offered at discount COVID rates, for the price of maybe what it would cost you for your cable TV. That's what you were paying for. And some were, the big challenge is learning what for these practices, how to do this and standardize the workflow, work out the kinks, and get a physician champion in the office who's willing to set an example for others, figuring out from a front desk end which patients are appropriate for telehealth, what visit types are appropriate for telehealth. You get a variety of opinions from providers on what is best for telehealth, but at least get everybody to agree on that so it's kind of organized. You're already dealing with broadband challenges for patients and that kind of thing, but they had to get creative. I mean, how do you leverage parking lots where patients can't come in, and maybe you have hot spots in the parking lot? But telehealth was really instrumental in helping these practices survive. And now, right now, we were on a call last night. There were 2 groups. They're doing maybe a third of their business still by way of telehealth, which is fantastic. And others have dropped off. Medicaid in North Carolina took a big lead in really changing what they covered for telehealth. And that helped us a lot, because if Medicaid's driving it, that really perks the interest of a lot of providers. So, and of course, all the payers were jumping in. And so we had to also help practices figure out what codes to use, because every payer had a different code for what they required to pay for the darn visit. And we don't have payer parity in North Carolina, so that's still an issue, although it's kind of pretty good during COVID. It could go back to the old way. So there are some insurance companies that pay you at the level of an in-person visit, and you got others that don't, and they won't until they're told to. So providers are dealing with that dynamic, but it's really creating a standardized workflow that's efficient and effective, and getting that to be a well-oiled machine. And then, people start to feel very comfortable. But if it wasn't for the pandemic, we probably wouldn't be talking right now. So I'll just pass it back to you.
So thanks, Chris. Again, I love that sort of like mixed blessing. I think that it's kind of an interesting part of the pandemic, because there's been some good points and some bad points, but also some good things that have changed. And So Nita, I purposely wanted you to sort of wrap us up here because in sort of the introduction, because I think you represent a really interesting perspective. For instance, most of the other folks here have a sort of live in a statewide perspective, and are also thinking about the support of physicians and other clinicians who are really focused on bringing primary care. You sort of bring together the unique perspective of being a practicing physician as well as actually supporting a national network, and would love to hear a little bit more sort of about you and your practices, as well as sort of the circa 2020 and circa 2021 experience for your network.
Yeah, thanks so much, Teresa. First of all, just to remind our practice types that we serve, we're a health center controlled network, and we support community health centers across the country. They represent 20 states, and those states include rural and urban settings. Our role is really to provide some supportive infrastructure for the community health centers in our network. And some of that infrastructure includes health information technology, a collaborative infrastructure for research and quality improvement, and also peer-to-peer learning. And we've used all of those throughout the pandemic and for telehealth as well. Some of the specific support has been in providing EMR content to help capture telehealth visits, creating a forum for not only clinicians, but health center staff to come together around what's been working and what's not been working as it pertains to telehealth. And then also offering some data and analytics to help us better understand what the experience has been through telehealth. And so much like my colleagues on the panel today, there was a very, very rapid surge. The one thing that I'll say is that was interesting to observe over time is that we saw that the distribution of the types of telehealth visits has changed over time. In the beginning, the response was, of course, like very swift to try to get virtual visits in place. And we saw a lot of visits that were taking place by phone. And gradually over time, we saw an increase in the utilization of audiovisual technology for telehealth visits. And much like my other panelists mentioned, we certainly did see changes in utilization based on where different locations were in terms of the prevalence of COVID, and what patients were feeling about coming into the office, what providers were feeling, and really making those adaptations. I have to say that the response from the community health centers has been nothing short of inspiring. That sense of trying to create access for patients to their primary medical home despite an inconceivable amount of disruption has just been really, really inspiring. And I will also say the spirit of continuous learning and making adaptations as we go, that ability to pivot quickly, it's been really amazing to see. I think that one of the things that we're seeing now, much like my colleagues have mentioned, is there's a shift. There are more in-person visits happening. At the same time, some of the survey data we've collected from our health centers show that there is a commitment towards making telehealth part of a long-term strategy for digital health. And commensurately, we're hearing from our health center partners that there's a desire to think more comprehensively about digital health and virtual care, and how we might think of incorporating things like patient engagement technologies for outreach and access in different ways, and how we might also think about remote monitoring technologies. So those are kind of the things that are factoring into contemplating a long-term strategy.
Thank you. I mean, I just want to highlight one other thing about the Alliance and the Florida network that they work with. And I apologize, Nita, I am not remembering the name correctly, but they have this fantastic webinar series that they do focused around sort of pandemic health management. And one of the things that was super inspirational was the way that even things that you might think would be challenging to convert to telehealth, they did, like obstetric care. It was amazing. So just if y'all are looking for very specific examples, I'm gonna point you at Nita to find some more of those, because their team did an incredible job with that.
Yes, it was a collaboration of Health Choice Network and Alliance Chicago, our dear sister network in Florida. Yes.
I mean, just really inspirational work, and it certainly was inspirational for me. as well. Now, I want to do this last question and sort of lead us into where Bob, I think, is hoping to take the sort of conversation on the bottom half of the hour, which is really thinking about the future of telehealth. Like, where does it go, right? And so what I'm going to sort of ask all our panelists to share with us is essentially help us think about, like, where were the big successes and where were the challenges? And I think that, and I just want to emphasize, I think the successes are just as important as what we need to do, right? Because the successes are where maybe we can reinforce and where we can learn as much as the challenges are. So I was going to start with you, Chris. Tell us a little bit about sort of what you thought some of the key successes and challenges were in your environment, and sort of where you kind of think we need to keep our eyes now that we're getting close to, I don't want to say the end of the pandemic, but we're starting the next phase, I think.
Well, I think that, well, this is just my opinion, and based on the feedback from our coaches. I think number one, it's been wonderful to see how quickly providers and staff have pivoted and quickly adopted to telehealth in such a short time frame. If you think about the time frame of them adopting the EHR from paper records to EHR, that was much longer than the time frame of adopting telehealth. But if you look at some of the things that I think are going to be really important, payer parity is really important. And if CMS takes the lead, all the private payers will follow. I think another issue is we've got to try to find ways where telehealth can be easily integrated into the EHR. Providers don't want to have to get their information or put their information into two different places. And that's what has happened a lot during COVID. They've done it to get through and get by, but it really needs to be integrated. And what I think we're going to find is that's going to be a financial hurdle for a lot of practices. So much money from the federal government has gone to rural health centers and FQHCs, appropriately so, because they're the safety net providers. But there's so many independent private practices out there that are not part of big health systems that we've seen so much stimulus money going out to practices like the Paycheck Protection Program and all that. But it'd be wonderful if there were funds to help practices integrate the telehealth or even the health information exchange into their EHR, because these EHR companies are charging a lot of money in one-time fees and monthly fees, making money on this. And unfortunately, the only ones really signing up are the specialists who have deep pockets, but not the primary care folks who are living, on the margins. And so I think that's going to be critical. I think lastly, one perspective I think is it might help us get a little bit more innovative with our health workforce. So if you're a small primary care practice in a rural area and you've got a provider that that may be living in an urban area, but wants to contribute, wants to still work, but maybe wants to do it by telehealth and not be on their feet all day, or they want to give back to the community that they grew up in, but they don't necessarily want to move there, they can potentially contract out and have that provider provide telehealth coverage for acute care visits or for urgent care, or that could be a way to kind of leverage the healthcare workforce, especially as physicians and providers are aging out. I think that's an opportunity. And it's also available we're all seeing it now, we're working remotely. I think that's an opportunity. Providers might be interested in working remotely, no matter what their age or where they are in their career. And I think finally, one thing I wanted to mention is I don't think we're always using our staff to the top of their license in these offices. So one thing we're seeing in some offices is they are really leveraging their nurses to do their annual wellness visits through telehealth and get that done. And it doesn't all have to be on the provider. So I think those are some of the opportunities, if you will. And I think if we can check the boxes on those, I think telehealth adoption and circulation would just go through the roof.
Wonderful. I love the point about engaging the full team. I mean, I think whenever we can really bring, it's kind of magical to think how telehealth could actually improve team-based care for our practices. So Patty, I'm going to move to you next. Add to what Chris said. What do you see the greatest successes and challenges right now?
Sure, thanks, Teresa. And I have to agree with Chris. The convenience, the annual wellness visits. A lot of practices, and I've seen in my clients that they're utilizing that, telehealth for that, and that's been a big win. But the big successes in our area in the Midwest here in Indiana, I would say that it's decreased no-shows. The no-show rate across the board has gone down tremendously. Like I said, the convenience of it, you don't have to pull your kids from school. You don't have to leave work earlier to run off to a doctor appointment. You can sit at the convenience of your, in your car, at your dining room table. So that's been a big win. Of course, behavioral health is huge for it. Some of the challenges with telehealth, again, like Chris had mentioned, the parity rules, the reimbursement, I think everybody could concur that reimbursement, and hopefully CMS will be the leaders of that, because if CMS does it, then all the other commercial payers usually follow suit. So hopefully long term that will stick. Some other big successes. I know I worked with one particular client. I worked with telehealth directly. We worked it's called a continuous collaborative improvement. It's kind of like lean methodology. Larger practice in Northwest Indiana, but we did just small little workflows. We made improvement on. Like they wanted to reduce the time. Their normal telehealth visit was running about 27 minutes. They wanted to reduce that to, make it more efficient, cost effective. And so we implemented small workflows where we, just like you do a regular office visit, rooming the patient, taking their vitals. We did that with the medical assistants. We would have the patients log in 10 minutes prior to their actual appointment with the provider, where the MA would room the patient, take their vitals, ask them all these questions. And so we established a standardized workflow for that. And we actually reduced the visits over a 30-day period down to 20 minutes, just by this small little piece. So working with practices on improving their workflows was huge. There was another one where we created a pre-registration functionality where we would have patients, they would get an email or a text message, please pre-register 3 days prior to your appointment. And again, that shaved off a considerable amount of time. Helping clients work with their workflows, improving their workflows. Education. A lot of patients are a little leery of technology. There's some that are really savvy. Everybody's got a smartphone, but doing Zoom, meetings, virtual meetings over your phone, some aren't so comfortable. So we spend a lot of time working with patients, the technology, maybe creating a cheat sheet for them or sitting with them an extra, 5 minutes over the phone and going over the steps how to do the telehealth visit. So those were some things that were a positive flow that we really helped out here in Indiana. Yeah, and I like Chris, the whole parity thing, it's here to stay. It's not going away. So anyway.
Thanks, Patty. And again, I'm just going to highlight workflows. I think that's a really sort of critical thing. And Nita, since workflows, I know we're near and dear to sort of what your teams were working on, I'll sort of open the floor to you next. Tell us a little bit about the great things and some of the challenges. Nita, don't forget to take yourself off mute. We want to hear you.
Every time. So I would say there were several positives. I agree with Chris and Patty about what an enabler the parity and reimbursement was and how critical the dependency that will be for the future, for sure. One of the successes was really being able to think about the clinical workflows for different clinical scenarios and what really lend itself well to an in-person visit and what could really be done very well through a virtual visit. So I think that's one way, one success that came out of this in terms of how health centers have produced that type of documentation and have been willing to share it across the network so other folks can replicate it. I also think this way of being creative of how to optimize the volume of visits, having a provider maybe see patients across multiple sites because they were able to do be remote and see patients that might be at different locations of care where there might be a medical assistant who can assist with vitals, and the clinician though could see people over very, very disparate locations. One of the really interesting workflows that emerged is the ability to capture social determinants of health in a very effective and streamlined way. Sometimes collecting social determinants of health using the standardized screeners, there are sensitive topics that might be difficult to elicit in an in-person workflow that were easier to elicit in a digital workflow. And so that was something that we observed, and I think really is something that will be useful going forward. Some of the other successes I will say is just, again, this ability to learn what different practice types are doing across the country. And so, a health center that might operate a rural location of care in Hawaii might be able to learn from one in Iowa. And so I think that that type of collaboration is a huge success. Personally, I think as a clinician, I just want to share that there was something so wonderful about being able to see the home environment of my patients during a visit. It added so much contextually to what the patient's learning environment was. If they're doing virtual school, I'm a pediatrician. Who all are in the household. I got to meet their pets. It was just a wonderful, wonderful experience to see all of that. Oh, and the challenges. So some of the challenges, reimbursement is kind of a double-edged thing, right? It's a benefit and a challenge. I do just want to highlight the digital divide that we've touched on a bit in terms of not just broadband access or access to physical technology, which is still a challenge for people, even though they may have a smartphone. If they don't have good internet access, it does make it challenging to conduct a virtual visit well. I think the other part of it is digital literacy. And I really think that's a tremendous opportunity for trying to support patients in how to engage in a telehealth visit or virtual care through remote monitoring. And I think that is a real challenge right now, but also a tremendous opportunity to offer patient-centered care.
Thank you, Nita. Like, as I say, I've heard a number of physician colleagues tell me exactly that same thing, that the ability to see where people are at, and maybe likewise for the patient to see you where you're at too, I would imagine, because it's sort of like, if you're sitting in your own home, they get that bi-directional view of you too, which helps, I think, sort of humanize our physicians and nurses and PAs and all the great people who are providing care for us. So with that, I'm going to sort of wrap up with Andrew. Tell us a little bit about where you're seeing with the sort of successes and challenges, and knowing that, as I know, your team does a lot of education on both sides of the fence, both practice level and some patient focused stuff as well. So.
Yeah, thanks. Probably one of our biggest wins was really our grantors like ARC and some others allowing us to switch early on to help provide practices with telehealth support. So we were able to build that in early on into our projects. In some of our projects, we used like Bodenheimer's building blocks. So we added another building block on telehealth and have steps kind of, phase 1, phase 2, phase 3 of kind of going through the whole process. So you're successfully implementing a telehealth program, and by the end, you're getting paid for both, clinical visits and behavioral health visits successfully. So our, setting up kind of that training program for the coaches briefly, just to kind of go over some of that early on material of, if you've never done it before, kind of helping support our coaches, and then our coaches going out and working with those practices directly. And then we're now able to, since one of the projects we really set up that kind of building block methodology, we're tracking over time where these practices now that implemented, back in March, April. Some of them are still wanting some assistance. Some of them kind of have moved on and they're successfully using telehealth. But the other thing we're able to do is to ask them, as part of data collection, what kind of barriers did you see in working with telehealth after you've implemented it? So we saw the same thing, payer parity was number one. But then looking at digital literacy, you mentioned it was huge. That was one of the biggest things we saw is from the practices. Something as simple as, patient comes on, is waiting for the provider to show up, provider's 10 minutes late, the patient leaves. So something as simple as having the medical assistant kind of start off that visit and let them know the provider might be a couple minutes late, but don't leave. So that really helped with even the no-show factor, that what little there was via a telehealth visit. So it's kind of really those kind of things. It was, just really fascinating seeing just the uptake that the patients, we heard a lot of positives from the patients. I think moving forward, really focusing on, assuming parity stays where it is or close to it, hoping that practice really focus on kind of, like Chris said, visit type I think is huge. It's like, how do you use it with your other types of visits that you're doing in person and make it really a value add, because patients want to have that as an opportunity. So. Thanks.
Well, thank you so much, Andrew and Chris and Patty and Nita. Your points of view are really wonderful, and I hope that this is just the start of a lot of conversation. I just want to tell the audience, a lot of these folks are really happy to talk to you and share, because I can see a lot of comments in the chat where there's a lot of things happening, people interested in learning more. And we will try to help facilitate if you have people you want to talk to more closely. So Bob, thank you so much for giving us the time to welcome people into my living room, as it were, for a little conversation. And yeah, I am literally in my living room, and I hand it off to you to lead us in the next part of the conversation.
Thank you, Teresa, and thank you, Andrew and Chris and Nita and Patty. That's terrific. The chat has been roaring, and there's a lot of good questions, and I want to get to some of the questions. But first, I know we had some folks join us from VA today. Marjorie Bowman, you've put in some great comments in the chat. Do you want to just say a couple words about what your experiences were that you might share with the team here?
Well, I didn't prepare by actually trying to find our data, which I know I have some of, but I can give you some of what I would say from telehealth and VHA. And as you know, we're across the country, and we're a system with a lot of individual uniqueness still at individual medical centers. But because VHA is essentially a huge capitated system, we were well along in this telehealth thing before it struck other locations. So we already had a lot of people set up for telehealth. We actually provide phones for some. We provide pads for some people who are homebound. We provide transportation to offices if necessary. And so we had and we were allowed to void certain federal rules that made our across state lines even easier when the pandemic hit. So we had emergency declarations that made it easier, for example, for our trainees to be involved. And since one of the offices I oversee includes our 120,000 trainees, that was extremely important to us. And so we probably already did more home health as part of regular health than many primary care offices would have done. We have a lot of people who do that for us. Pharmacists make certain visits. There's a whole variety of people. The visits sometimes are 2 or 3 people going to the home too. But the telehealth went off dramatically. And now we're back to where we're doing telehealth, and our visits have come back to almost normal in almost every place in the country, depending on where they are with the pandemic still. And some of our sites are busier than they were and doing telehealth. Wow. So it is, we provide them blood pressure cuffs, thermometers, and I used to work I used to be in North Carolina at Wake Forest, and we were involved with a fully capitated program for a while when it started. And we did a lot of this stuff when we were fully capitated. So fee-for-service drives this, and how you get paid drives this. So it's not just fee-for-service, but fee-for-service makes a big difference. How telehealth will get paid for makes a big difference. And I wrote in the chat, if CMS doesn't pay for it, it won't happen. Right? They drive too much of the rest of the reimbursement system. I think telehealth, and for us, it's very clear that telehealth was most dramatically, is going to most dramatically continue in mental health. There's just, it's, I think we've already had surveys, and both the patients and the clinicians say it works as well or better sometimes, because you do have a window into the home that sometimes you otherwise never see. Kind of like us family docs who used to do some home visits, you know, and you would walk in and you'd say, oh, I had no idea, you know, the things you can discover. So I think that's some of our experiences, but if people have other thoughts or want to ask me questions, I'm available. I should say who I am. So I'm the acting Assistant Secretary for Discovery Education and Affiliate Networks, which means I oversee the Education Office, the Research Office, the Innovations Office, and Care and Payment Innovations and Community Partnerships.
Well, that's a great title too. I love the discovery part in particular.
Yes, well, now Carolyn Clancy was in this role, and we swear that Dean, D-E-A-N, was her thought process, but I might be wrong. She's currently the acting Deputy Secretary for VHA, which is why I'm in this role.
Well, that's great. Well, thank you, Marge. Thanks for your comments and thanks for sharing. I'm going to get some of the questions in the chat because there were a couple really good ones, I think, for the panel and whoever else. And feel free, if you have thoughts about these, answer them in the chat too. So Ashley Edwards asked if someone can talk about quality and outcome measures for telehealth, assuming it's here to stay in some form. Anybody dealt with outcomes? Because I think this will be part of your point about if CMS doesn't do it, you know, nobody else will. And we really need outcomes may be important to that. Anybody have any insights on outcomes from telehealth at this point, measuring it? Anybody on the panel? And those of you at home, if you have thoughts about it, feel free to share. Yeah, Chris, did you have something? No?
Hey, Andrew, you mentioned at the beginning that you were measuring the use of telehealth. Anita, I know you've also done a little bit of measurement in this space. Do you guys have any insights on this piece of it? Is it hard to measure? Maybe that's a good question. Is it hard to measure?
I mean, the volume's the easy part, right? So, but yeah, the outcome piece is, I don't know if anyone has a good idea on that, but.
Well, and let me just reframe a little bit. Oh, go ahead, Chris. Yeah. Fire away.
Yeah, I'll just comment. And what we did encourage a lot of practices to do, the practice facilitators, our coaches work with them one-to-one, elbow to elbow, on a lot of these workflows and pre-visit planning and all that stuff. One of the things we encouraged them to do is, the people we were really worried about during COVID were those with chronic illnesses, because if they got COVID, they were more likely to be in the hospital or to have serious side effects. So we encouraged providers and staff to pull data out of their EHRs, focusing on everybody who was hypertensive or diabetic or obese, or the elderly. Let's just work down the list in a systematic way. Targeting those populations to make sure they're getting the care that they need. And for those that are where they have the ability to hook up with you on via telehealth. But that was one thing that we did and just kind of making sure that we could still manage to the best of our ability those patients who were diabetic and they were hypertensive, so that at least our outcomes in those areas are pretty good. And then the other thing is on transitions of care management, when patients get discharged from the hospital or the ER, and you have to follow up with them, leveraging telehealth to follow up with them at home. And then you can also bill for it. But it's a twofer. You're taking care of the patient and you can also bring in revenue, but leveraging telehealth because they really couldn't come into the office. So those were a couple of things that we would do to kind of look at a numerator and denominator to see, are we making enough traction in those buckets of with related to chronic illnesses and those that have been admitted or discharged from the hospital.
Interesting. Well, because that sort of answers, the other question I was going to pick up on is Adolfo asked if somebody could discuss whether we have information comparing quality of in-person visits versus telehealth visits. That sort of speaks to it a little bit. Does that anybody sort of track on that piece at all? It's sort of related to the outcome piece, because that'll be critical.
I'll just say that on the mental health, the patients and the mental health providers both said they really liked it. Great. That they felt it worked well. I will say in the private world is that I suspect there will be, we're going to see malpractice claims, whether or not they're legitimate, but I think it's an area where some lawyers will really tackle this and say, oh, it was because of telehealth, you didn't do what you needed to do. But I think there's a struggle around that because patients often want the telehealth when you want them to come in. So I think it's an area where clinicians will probably start doing some of the same stuff we do, which is say, patient refused in-person visit, doing telehealth instead or something like that.
Right.
Well, I pick up where you just said about behavioral health, though. That is where we've seen the greatest retention of telehealth is in the behavioral health realm. And I mentioned a call last night. We had a pediatric office that was talking about their telehealth rates, but when then you got into the detail, the person that was most active with telehealth was her behavioral health provider.
Well, and actually what we've seen is they are retained better. So, one of the big issues in mental health is dropout. And if you do the telehealth, actually they may stay in better. So we think we may end up with better outcomes on mental health than we have with the in-person visits, but maybe not for everyone. But I think that in a number of situations, there's reluctance to travel and it's expensive, it's time consuming, et cetera. Well, getting access for so many of our PTSD and various post-trauma patients through telehealth, and it allows us to outreach to them even when they don't set up a telehealth visit. It makes it easier. You've done it before, you can do it again.
That's great. Anita.
Yeah, a couple of thoughts. I think the quality outcomes is such an interesting one because we gave this a lot of thought of how do we look at certain metrics? Do we try to prioritize the ones where we think that they could be done easily through a virtual visit? So some of those would be like substance abuse screening or depression screening or things of that nature where you didn't necessarily have to have an in-person visit, or where the actual measure guidance allowed some flexibility in the measurement criteria for remote monitoring, such as blood pressure and things like that. So it's an interesting issue to grapple with, and how you look at the data is complicated. I will say this concept of, is the quality of a visit in person the same as the quality of a visit in terms of diagnostic accuracy, in terms of patient experience? That is such an amazing area for research, I think, to be able to think through that.
That is, this is Adolfo. This is exactly the reason why I asked that question. We had a randomized control trial that we were aborted with. We had that stopped, halted right now for patient recruitment because they would like to have a better understanding on the quality and the interactions when they are telehealth versus in person, and what is the impact of receiving therapy in those two modes. There is no data, so that's why I'm appealing to all of you to help us create the data. Yeah,
Let's help you. Yes,
yeah.
That's great, Adolfo. Well, and so there's a bunch of other questions. I just threw one out to everyone. I'd love everyone to try to respond to what one thing do we need to know to make telehealth part of the future of primary care. And I think there's a couple other questions. Let me just pick on a couple. One, somebody asked about best practices around around triage. Anybody been talking about best practices around triage visits? Feel free to answer in the chat. Anybody on the panel have any experience with that? Not hearing too much. Okay.
We've definitely had some standard operating procedures that have been shared by the health centers and some of these peer learning groups that I mentioned in terms of how you would go through a triage workflow and make that decision.
Are you referring to triage?
Go ahead, Nita.
No, it's a good question. I'm assuming you were referring to clinical triage or how you triage a visit type. Bob, is that right?
Yeah, I'm just looking at the question. Jade asked it. Let me just see. It was, can you share best practices that have been identified for patient triage, in-person versus virtual? So distinguishing whether somebody needs to come for an in-person visit or a virtual visit.
Yeah, I think several of the health centers in our network have done exactly that. They've developed standard operating procedures. So when the nurses are working through, triage calls, they can make a determination of who should be triaged into an in-person visit and who could be triaged into a virtual visit, for sure.
Got it.
They've also done it at the front desk end as well. If the providers get together with the nurses and the staff and say, these are the visit types that are appropriate for telehealth. And then when the staff are interacting with the patients, if they know what visit type it's going to call for, and based on their knowledge of the patient and their circumstances, they give the patient a choice. You know, would you prefer to be on come in person, or would you like a telehealth visit? Because they know that particular visit type would be okay for a telehealth visit if the patient is comfortable with it. And, you know, you don't just force the telehealth visits on the patient. You kind of have to give them some choice, but hopefully we would address some of that legal liability. But that there is a lot of pre-visit planning that goes on with algorithms and scripts and things like that, both on the nursing and on the front desk end.
I think scheduling software too has to be taken into consideration because we have a whole new scheduling component to it. So I agree with everything that's been said of, you know, we need to, you know, go through an algorithm of how we do this. But then we have providers that thought this person was going to be in here in person, and it's actually a video visit, and they didn't know. And so a whole different scheme of how do you schedule and how do you inform providers, and is it okay to bounce from in-person to virtual visits, or do you block off a half day? Those are all things that have to be answered at the clinic level.
I have to agree that having those discussions, as we talked earlier, teamwork, key piece there, gang. Everybody working together, and every practice is different. And so you need to have that talk, what patients are good to be seen telehealth, and having scripts ready for that front desk person, and practice this, you know, and have something in place. But those talks have to be done internally. Every practice is going to be a little different on how they feel, if that patient is good, and asking them, like Chris said, ask the patient, would you prefer a telehealth visit or in-person visit? And, you know, I think 9 times out of 10, most of them want telehealth.
Our health systems are starting to set thresholds, and it's interesting to watch because some systems are setting thresholds that they want telehealth increased, and other systems are setting thresholds that they want telehealth decreased. And we can't figure out, being a neutral body on the outside of things, we don't know the difference. We don't know what they're shooting for. So.
Well, some health systems are actually, if they know the patient's insurance and whether they're going to get paid or not, that's another thing that factors into the algorithm. Does the patient's insurance pay for it? A lot of these EHRs right now, a lot of the telehealth vendors, it's not that sophisticated. So I think the tech side would have to keep up with the what is actually getting paid for in order to even offer it in the first place.
Well, that's great. Thank you, Chris. And thanks to everybody. I mean, I feel like we've barely dented the surface of this conversation. But wow, so much out there. I think this could continue. We should continue having some conversations like this. We're going to capture the chat. We've recorded the session. We'll try to make it available. We'll have a sense for, you know, you have an email, and actually maybe if you just put up that last slide, Elizabeth, you have an email address to stay in touch with us. We'll continue to connect. Let me let you know that we have our last scheduled primary care learning community session is going to be next month on June 30th. And we're going to talk about connecting primary care and public health, better integration of primary care and public health. We have a great panel that we've put together for that. I'm sure we'll have as rich a discussion for that session. Let me actually thank the panel, all of you. Teresa, thank you. Andrew, Chris, Nita, Patty, terrific work. Marjorie, thank you for being a guest panelist. So appreciate that. And thank you for your comments. There's so much we didn't cover today. And let me just look to my boss, Arlene Bierman, to see any last words, Arlene, as we head out for the day.
You know, thanks everybody for such a rich conversation. And, you know, there's a huge research agenda here, and we do need the evidence going forward to really improve, expand, you know, transform primary care. So I just want to let everybody know we're in the process of developing a research agenda for ARC for the next decade. And all of this will like factor into our thinking. So it's really, really helpful for us. The other thing is, you know, we'd really like to hear from you about like how a learning community could help you, because we're thinking about, is this something that we should build on in the future? And if we do, like what would make it useful for you?
Thanks, Arlene. And there's an email address where you can send us your thoughts. Thanks again for joining us today. What a terrific discussion. So much more to be said about this. So thanks again to everyone, and have a great rest of your afternoon. Bye, everybody.
Bye-bye.
Thanks, Bob.